Well, thanks everybody for being here today, and remotely. I appreciate it. Thanks to Phil's family for being online and in person, friends, colleagues. We're very excited to have Gail Jensen here for the first annual Phil Hageman Memorial Lecture. So for those who don't know, 4 years ago today, we lost a son, brother, colleague, physical therapist, teacher, mentor, and a great friend of mine. I had the privilege of meeting Phil Hageman in 2020 as we entered the inaugural cohort of Northwestern's Orthopedic Fellowship. We grew close over that difficult year, and I look back on it very fondly. Phil was one of the most kind, funny, passionate people I've ever met and was an amazing physical therapist and educator. Phil brightened every room he walked into with his cheerful demeanor and left things better than he found it. He's an inspiration to me to always give back, be thankful for what you have, and to encourage one another. Phil was passionate about lifelong learning and empowering growing clinicians, and he's one of the reasons that I went to build this program. I'm very excited to honor him today by beginning this annual lecture series in his name. I think ways that we can remember Phil, even if you didn't know Phil, ways that you can remember him on a daily basis, treat others with kindness and encourage one another. Every May for his birthday month, we move, cycle, run, swim, and row for Phil. You can use that hashtag May Miles for Phil. You can teach, become a clinical instructor or mentor to give back. You can advocate. Who's a very fierce advocate for bike lane safety. Very passionate about that. PT access. And then there's also some scholarships in his name at Creighton and Northwestern to help others access high quality physical therapy education, especially residency and fellowship. So we're very excited today to have Gail Jensen, our inaugural Phil Hageman Memorial Lecture speaker. Dr. Jensen is a Vice Provost for Learning and Assessment, Dean Emerita, and Professor of Physical Therapy, holds a secondary appointment in the Department of Medical Humanities at Creighton University. She is known nationally and internationally for scholarly contributions in expert practice, clinical reasoning, professional ethics, and interprofessional education.
You could stop there.
I could keep going. I'm gonna keep going. She's an author or co-author of over 100 publications in peer-reviewed journals and has co-authored 15 books. She has led the research team that completed a national study of excellence and innovation in physical therapy education funded by APTA. She's been instrumental in the creation of and implementation of grant writing and mentorship in education research. She received her PhD in educational evaluation with a minor in sociology from Stanford, and she holds a master's degree in physical therapy from Stanford and a bachelor's degree in education from the University of Minnesota. Please give a warm welcome.
Thank you. And let me start out by saying that it's a real honor for me to be able to do this. And I think you're going to see going through here, there's a strong theme, and the theme is all about Phil. And Phil is an extraordinary learner, an extraordinary student, and really passionate, committed to clinical teaching. But he understood context, and that theme is going to come up again and again, how important that is in clinical reasoning, which I care pretty deeply about. So what makes an expert clinician? I mean, Phil was almost an expert clinician when he was a student. And can you be both an expert clinician and a skilled clinical teacher? Yes, that was definitely him. A few photos which you've seen, and those are Phil's parents up there, and that's a picture from our awards, our scholarship awards at Creighton. There's an endowed scholarship in Phil's name. These are from you all that we collected. Kyle and I collected some comments. We gave questions out to some of the colleagues and asked for three words and then a quote. You can go back. I'm not going to read them, but you can see by the bolded words: witty, thoughtful, patient, calming, present, friend, teacher, joyful. Kyle said several other things: humble, funny, kind. I mean, he had this kind of magical presence. He was present, he was mindful, and he really touched every situation he was in. He touched people. And what you see, this is the Memorial Scholarship that's at Creighton. which is now endowed. Phil was also, went on our ILAC, our trips to the Dominican Republic, and is part of that, but his interest was also in teaching and mentoring. And in doing a little bit of background, I found at Rockers, his undergrad at Rockers, which is another Jesuit school, and they made the bicycle repair shop. And we know that Phil was never seen without his bike. He was coming to campus. This is very interesting. This is from, I teach the ethics course, and I have the students do a free write. And this is, so he was a third year student, and he wrote this, and you can see the insight about, I don't agree that every patient should be defaulted to an extended treatment plan. So yeah, he's efficient, right? He's thinking. Okay, but then good clinical reasoning can help therapists develop appropriate plans, effective communicate the diagnosis, the prognosis. The true value of sound clinical reasoning. He's saying all this stuff. He didn't have a course in clinical reasoning at this time. Maybe he was reading beyond, but this was, fifth semester of study in the program. So you can see, pretty an incredible learner. So he was really what we call a true master adaptive learner, an adaptive learner who is a lifelong learner, always engaged in that learning. And we're going to talk about a few things with some strategies of what you all can use, not only as residents, but as mentors in residency education. Clinical reasoning is, I think, the holy grail. And what sits behind that is that metacognitive process, and that's universally understood. However, the problem with this, can I walk across?
You may walk.
I like to roll around. What's challenging about this is it's like the fable in the elephant. Which part of clinical reasoning we're going to focus on? Is it this? Is it that? Well, I'm going to talk more about there's work now in people saying that really the folks that are doing cutting edge work in clinical reasoning, that context is what clinical reasoning is. If you don't get the context, you're not going to be very successful. And that's really true for PT. A lot of interest, a lot of books in every profession, and a lot of papers. One of the people who's been very kind to physical therapy and involved in our education research mentoring program is Steve Durning. And Steve is an MD PhD at the military school. He's also the associate editor for academic medicine, and he is probably the most well-known education researcher in clinical reasoning for medicine. And I followed his work for a long time. And I reached out to him at one point and said, would you consider coming to PT and giving a keynote? He goes, yeah, I would. And that was about 6 years ago. I mean, he's been terrific. Okay, so why, what, and how? That's what we're going to talk about. Why is it so important? What is it? The elephant, and then how we teach it. So those are the three things. So what is it? Why is it? Well, okay, effective patient care, safe practice, diagnosis is part of it, but it's probably more important for medicine than it is for PT. We can talk about that. And then it's important for your continued growth. Lots of definitions about clinical reasoning. Just to see the highlights, you'll see some of the similarities. It's both, this is medicine, but it's both cognitive and non-cognitive. And we tend to overemphasize the cognitive, but the non-cognitive things, cognitive, how you put together your knowledge. But if you don't understand the patient, which you all residents, you all understand, if you don't understand the patient, good luck, right? And the context-dependent way of thinking and decision-making, the construction of the narrative, and you're going to see later in a couple of the structures of the models how important that is. And physical therapy, reflective process of inquiry and analysis, understanding the patient, context, the psychosocial philosophy. This most recent, a really nice infographic that was put out by Karen Hume and Sarah Gilligan, Lisa Black, and Nicole Christensen, about they've really been looking at the role of movement in clinical reasoning. We got so many different wash shoes, you should be all over this, right? How important the movement piece, the multi-sensory, because we are about movement and how we understand that, and that becomes part of our reasoning process. And this is a paper that was a classic paper, New England Journal of Medicine, and then it was revisited, and it's a great paper. I will send that to you too. And it is annotated, and all the annotations in this paper are about context. And how important the context, patient preferences, understanding that is essential in the reasoning process. So key points about clinical reasoning, yes, theory is important. I'll talk some about theory. The diagnosis co-created, and even medicine's talking about this, co-created by the patient and the team and the health professionals. It's not just us, right? And you've got to think analytically and non-analytically. We'll talk about this. And most recently has been, I'll also send you this paper about emotions and clinical reasoning, how positive, also negative emotions can have an impact on the reasoning process. Pretty interesting. Okay, what do we know about our jobs? They're very hard, whether you're a teacher, a clinical teacher, or a therapist. Why are they so hard? Because we don't control patients and we don't control you all. We don't control students, we don't control learners, we don't control patients. They have to do something to contribute to the outcome. So that makes our work very difficult. It's not like we go in and cut something, do something. So this is the complexity of how we get human performance as human in some way. Clinical reasoning, all health professions, all professions have these three things: habits of head, mind, hand, and heart. But clinical reasoning is across all of those components. In our national study, we would argue that the professional moral foundation is really, really essential. And ethical reasoning is definitely part of your clinical reasoning process. Okay, so what is it? Lots of terms. This kind of a blur here. These are the kinds of things. This is the elephant approach here. So what is clinical reasoning? There was some great work done early on by Ian Edwards, Mark Jones. Well, it has in PT, it has a diagnostic piece, it's procedural, it's narrative, it's clinical judgments, it's ethical reasoning, it's critical thinking, it's problem solving. All these terms are kind of thrown at clinical reasoning. We'll sort some of these out. Probably the most important piece, which we'll get to, is the thinking about your thinking. That embedded cognitive process is central. Clinical practice guidelines, you use them, right? And I titled this kind of beyond the clinical practice guidelines. What I love about students is they go, where's the first thing they're gonna look for? Yeah, what does the CPG tell me? It's just a start, it's a scaffold, but it doesn't give you the answer, does it? No. So I think it's helpful, but the reasoning process has to kick in, and that's where the context, the complexity comes in. But they're important, right? Yeah, everybody's not. And you're familiar with these in residency programs, mentors, all of this about. So this is the domain of competence on clinical reasoning from the residency competencies, core competencies. And what's important in the clinical decision making is that rationale for decisions, the role of the interprofessional team. And again, here you see incorporating patient needs and values in the context. All right, this is from a recent the old Institute of Medicine, which is now called National Academies for Science, Engineering, and Medicine. And they brought together cross health professions to talk about diagnosis. But it's just an interesting framework. It's a little linear if you look at it, right? The communication of the diagnosis, the treatment, the outcome, what has to come in here, the working diagnosis. Most of these models, they look somewhat similar. I think there's some unique aspects for physical therapists, and you can continue to think about that, because I think we do have a special piece that we do in the reasoning. Part of it's movement, part of it is context and how skilled we are at teaching and learning and getting patients. This is also from this same document that just came out this spring. And what's striking about this is you start down here, okay? You're going to fix people who are passive and well, that doesn't work, does it? Maybe it does for some, but you've got to do something. You've got to engage and involve people. You can't get anybody to learn if you don't engage them in the learning, right? And now how do we also get co-production, co-design, collaboration, and working with the patient?
it's kind of the movement where they're trying to go to advance diagnostic excellence. You're gonna agree or not agree, I'll send you this document. Great. Okay, so what did this document came out with a number of recommendations which all make sense. So we'll talk a bit more about type 1 and type 2 thinking, slow and fast thinking, hypothetical, deductible, pattern recognition. It's important, it's kind of a basic concept. This is really important, deliberate self-reflection practice. You gotta practice clinical reasoning, just like you have to practice manual therapy. You gotta practice reasoning, and you gotta practice with simple and complex cases. That's really central. And how do you do that? Well, scaffold. So models can be helpful. Your mentors can help you. They can help you reflect more deeply. Really important. That's why the residency and fellowship programs are so wonderful, because they help accelerate, I think, the learner with your reasoning process. No question about that. And then we've got to train faculty. Faculty educators need to understand what you're doing and what's the role of all these elements, including not just the coaching process. Coaching is quite popular now. It's how do you mentor, but how do you coach and give feedback, which is part of mentoring, to help the learner move forward. And frameworks, we'll talk about frameworks. There's one pretty popular in medicine called the assessment of reasoning tool. And again, deliberate practice in simulated environments as well as clinical environments. Excellence, diagnostic excellence is a core competency. We wrote a paper, a short paper. Jen Furs was the first author on it. It was a point of view in PTJ, and it was based on a paper that Steve Durning and others had written in medicine, that clinical reasoning, with all the work on domains of competence and competency-based education, should clinical reasoning be a domain of competence? It is in residency education, and it's not right now in what's the essentials that have been put out in PT education. The document that came out in July, there are 8 or 9 domains of competence, but clinical reasoning is not one. The idea is same in medicine, that reasoning is everywhere, that it's integrated. But the argument is, if you're not more intentional about it, and if you assume it's integrated, I don't know, is it? Maybe not, I don't know, that's the challenge. And this is also pretty important. I think the profession needs to pay more attention to this, because guess what? The people that we're all going to be, that we all work with, it's people like Judy and me. It's people, it's older adults, right? That are not geriatric, but that's what your patients are. Okay, so a little bit about theory. Here's where we're trying to go, but guess what? How many tests have you taken? How many multiple choice tests have you taken? The tests are over. Well, until you take them, right? The clinical specialty.
Yeah, March.
Okay, all right. Yeah, but practice is more about this. That's the challenge. And wicked problems, right? You need wicked solutions. But this is really important, you know. How do we prepare learners how to learn, how to be adaptive learners? How do we get, give them a fish they feed per day, but teach them how to fish. So it's that teach them how to learn and how to continue to learn is really, really central. This is one of my favorites. It again shows our challenge. You just think about your PT education, right? How much time you sat in class, right answers, the bigger our class sizes, the more that we have multiple choice tests, right? The board exam, which is a minimal bar. But you go into practice, and guess what? You've got declarative knowledge, you've got how do you do things, procedural knowledge, but then you've got what we call clinical practice-based knowledge, practical reasoning, because that's what's coming out of practice. You've got to take this knowledge, and it's got to get transformed by your reflective process. That's what has to happen. And that happens through your reasoning process. We can't talk about knowledge, clinical knowledge, without talking about thinking. Clinical reasoning, those two come together. I think sometimes we get confused. And the other thing that happens is things that happen in the community of practice, in patient care, that's the most powerful learning ever. lots of evidence, it's very sticky. And you can just think about how you remember your practical exams. Why? Because they're loaded with emotion, whether you do well or not so well. Or when you do your mentoring sessions where you work with the mentor, right? And you have to go through the patient case for more high stakes, yeah, you remember that. So things that happen in clinical practice are really powerful because they're situational. Okay, what are the dimensions of reasoning? And we'll just to point out that, okay, it's the non-cognitive factors around the patient that's essential. How you organize your knowledge, and the way you organize knowledge is, yes, whether you're using type 1 or type 2 thinking, but you're also building that clinical knowledge. We know what we know about experts. Are experts, do they have bigger brains? Can they just memorize them? Can they hold more in their head? No. What do experts do? They have their knowledge is really organized well. So they found a way to put together their schema in their reflective process, and they begin to think in terms of scripts, pattern recognition, the way they store their knowledge is different. If some of that's from deliberate practice, some of that's from engagement. Really important that clinical reasoning is not a skill. Do not call it a skill. Because it's more than that. It's knowledge, it's performance, it has skill in it, but it's more complicated. All right, and cognitive and non-cognitive. You've heard of some of these, right? Yes or no? Yeah. Yeah, we're really guilty of cognitive load or cognitive overload. Every DBT program in the country sins about this all the time. The drinking from the fire hydrant, that's cognitive overload. Steve Durden is fond of saying, the learner can hold on to about 5 things. And if you're up to 6 or 7 or 8, you've lost them. So you have to be careful with cognitive load. Dual process, this is the system 1 and system 2 thinking. Slow thinking, which is more deductive, working hypothesis, gather evidence. Faster thinking is more pattern recognition. You understand the script or the illness. Experienced clinicians start to see patterns. How do we teach students? We teach them with slow analytical thinking. But they get in the clinic and they see their CI or their mentor and they go, oh, wait a second. They skipped a step. I'm like, yeah, they did. So that's where early learners, novice learners need to ask questions. Why'd you do that? And so experienced people need to talk. Those think alouds is one of the most powerful strategies you can use. What were you thinking? How did you get there? Why did you take that shortcut? Why did you ask that next question? And, you get the inside out. It's really, really important. It's also important for novices to talk about their thinking, even though there might not be much thinking. They need to express it, and they need to feel safe to be able to do it. And schema or script, this is just how you build the knowledge structure. These non-cognitive things have everything to do with what's going on in the clinical environment with the situational awareness. Are you aware of what's going on, or are you like a novice just going down, your examination and your evaluation questions? And emotion and motivation, situativity. This is the social cognitive theories, what's happening in the community of practice, which is learning all the time, because you've got colleagues talking to one another. You're constantly learning from one another, depending on how what kind of work affordances the learners get. You get more as you get more experience. Residents get a lot, right? All right, another comment about it's not about right answers, it's about learning. It's about how we develop the learner. It's about learning theories, both cognitive and non-cognitive. But then how do we get the learner in learning here to understand that they take responsibility for that themselves? Discomfort or struggle or uncertainty, the reflective process, self-monitoring, that's essential to your learning process. But if all we're doing is focusing on right answers, we're never going to get learners here. That's why I think, residency and postgraduate programs are so powerful, because of how they get they're learning through practice. It's practice-based learning. There's uncertainty there. And they're guided in such a way that learning is powerful and intentional. It's really, really important. The thing to worry about with learners is if they think they're great and they're not. That's a problem. And I'm sure you've come across. I nailed that. Boy, I really nailed it. Okay, a little bit of an eye chart, but once again, just again to point out the learning cognitive load, and you can see about that we tend to put too much load, and in advanced learners you can start to vary your cases, compare and contrast. It's very, very powerful strategy. Deliberate practice, really important. Dual process is system 1 instead of system 2. And we're going to repeat some of the slides. Will repeat some of this. The schema is how you conceptual concept maps, or another way. How are you beginning to structure your knowledge? And this is where some of Maitland's early work with the clinical signs and symptoms. That's a way of kind of getting a schema of what's going on. How do you make sense? And clinical practice guidelines do some of that too. How you make sense of of the presentation. I think that my pushback against clinical practice guidelines, if we only run around and say, well, where's the evidence? If we don't have evidence to do that, it's like, do you understand that there is that challenge? Do you understand this patient at this particular time and their preferences? That's got to be considered. Okay, this is just backward reasoning and forward reasoning. This pattern matching, fast thinking system 1, slow thinking system 2. And again, they're the same, weighing the evidence, but how you're going slower here, and this is what you do with experience. Much more into it. These are important terms. People say, well, clinical reasoning is all about critical thinking. Well, it's a piece of these terms all connect. Critical thinking, it's that higher order cognitive skills, thinking, deliberate about your thinking, reflection. If you don't have it, the old adage is, okay, somebody comes with 10 years of experience. Is that 1 year times 10, or is it 10 years of experience? The only way you get 10 years of experience is you've got to engage in a reflective process. If you've never engaged in a reflective process, your self-awareness about what's going well, what's not going well, how do I improve, you're never going to have 10 years of experience. You got 1 year times 10. This metacognitive process is that you're setting goals, you're approaching, you're monitoring, you're thinking about your thinking, you're making adjustments along the way. And then the self-monitoring, the self-awareness, things are not going right here, I think I need to adjust. And there's very interesting work going on now. Some researchers in Toronto at the Wilson Center about how important productive failure is. So you think about the last time you failed, great experience, but did you learn from that? So they argue that if we don't have learners engage in some kind of productive failure, some kind of struggle, that uncertainty, if we don't find situations where they're doing it, they're never going to learn. How important that is for future learning. So it's back again to the kind of thing about the right answer and how important the context is. And this is what people would say is kind of the holy grail when it comes to clinical reasoning. Learning how and what to learn, that metacognitive process, which is part self-directed and part, it is what is a lifelong learner. And this has been talked about. We don't now, the work and expertise doesn't talk about, oh, I want to become an expert and get all, credentials when I get my residency or I get my fellowship, that'll make me an expert. Well, not exactly. That adaptive experts are able to do routine practice, but they're also able to engage in progressive problem solving and come up with novel solutions when they're stumped. That's so they can do both routine and complex problems. Very, very. And this again is this adaptive, the ability to be adaptive, it's, everybody's talking, you're the master adaptive learner. And it is that, that ability to reflect, to be self-aware, and that you can come up with, you're efficient, you've done deliberate practice, but you can also adapt and come up with novel solutions when you're stumped. And that metacognitive process is really, really central. Okay, clinical reasoning PT, how are we doing with time? Good, okay. This is from work we did 20 years ago, probably more than 20 years, maybe 30. But with that, we studied experts, Lori Hack, Jan Dwyer, and myself, and Kate Shepard. And I studied the ortho folks, and we also studied clinicians in neuro and geriatrics and peds. But we studied experts in practice. And what we found, it was qualitative, and we developed a conceptual model, an expert practice model. This model really kind of still stands the test of time. It shows that, we only had 12 subjects, but it was theoretically grounded in that grounded theory, right? So we argued across all the different clinical areas that the knowledge for these expert clinicians was multidimensional and patient-centered. Their clinical reasoning process was collaborative. Their movement was very focused. It was focused on function and virtues. They had a deep moral commitment in what they did. And that all came together as their philosophy of practice. Now, we also argued that students may have these elements, but they're not connected at all. And as you develop more expertise, as the novice develops more competence, they begin to move these areas together. Their reasoning, their knowledge, understanding of movement, their sense of professional formation or vocation. So you can see how important that is. This is one of the quotes from one of the experts I studied in the ortho area. Actually, it was Peter Angelo. Impeccable evaluation skills, screen, prioritize your exam. You have to interpret the data, communicate to the patient. You need the patient to become their own therapist. That's true. There's context, and there's the other thing that was really interesting is we interviewed all of our experts 10 years later. Many of them were already in a DPT program, even though they were all active clinicians. So they were definitely lifelong learners, and they taught a lot. Joe Farrow was in my group too, you know Joe. And Joe, they're focused on how hard it is to communicate. Working on their communication abilities. You guys working on your communication? Yeah, it's tough. It's that listening, making sense. Which probe do I need? Do I really understand? Really important. Okay, what about models? There's a few models. I love this quote. All models are wrong, but some are helpful. So you may recognize this. This is a Maitland model, really. And it first came out, and it was just this. Very analytical, hypothetical, deductive, collect the information, knowledge, the biomedical knowledge. But then there was an insight. Oh my God, you better pay attention to the patient. Because what the patient brings to this, how they understand their problems and issues, and whether they're able to follow through, you don't control the outcome. That has everything to do with your reasoning process. And this is for me on Amtor's dissertation work, but you see some of the same thing. Yes, the left side is important, the biomedical, all the signs, symptoms, understanding that, but the patient and their world, their lived experience, patients haven't come to us with illness. They don't come to us with a disease. They don't say I have an adhesive capsulitis. They say I can't reach up in my cupboard, my arm. So understanding what's going on with them is absolutely essential. And I think the more expertise you have, the more you understand the context, better clinician. And here's another one. This is the kind of model that's used a lot in medical education. And it's quite similar. You can see patient story, really important for unconscious bias. But you still have to know what you're doing, right? You still have to understand the knowledge, and you have to be able to do that analytical process as well to do your diagnosis. This is We should practice the script tool. Does anybody use the script? Do you guys use the script tool? I do, yeah. And it's, again, it's a model, it's a scaffold. This is an example of a scaffold. So and it gives you, Maitland's work, I think early on was really spectacular in providing structure for thinking more deeply about what you would do in the orthopedic. And this is that assessment and reasoning tool. This is quite popular. There's a journal called Diagnosis, but this art tool is well known. And again, you can see some of the similar things. But thinking about learners have to progress. So there's some kind of rubric or progression. That's true with all learners as they move along. And this is most recent this is an infographic and Karen Hume and colleagues, really thinking about clinical reasoning in PT. What's special or unique about PT? Movement of the patient and the therapist, our communication about movement. So I think those are things that are very much under our. This is another orthopedic manual therapy PT, a modern definition. What's interesting here is patient focused, okay, activity health coaching, which is the complexity, I think, and the targeted exercise prescription. So if things are changing in terms of health and wellness and how patients come to us. But again, context. Context does not impact clinical reasoning. Context is part of clinical reasoning. And that, to tie it back to Phil understood that when he was a student, and you kind of say to yourself, how is that possible? I don't know, Mark, how is that? Do you think that way? I don't know. Yeah. So there was something special about that kid, that he really had this sense of humanity and understanding the human condition, and that patience and wisdom to care. I mean, he was really an old soul. I think we all, faculty said that. Yeah, yes, he rode his bike and everything else, but he was a deep thinker. Whew. Okay, teaching, learning, this will be, what time are we?
We're good, 3:12.
No, we're good.
Yeah.
We're great. Hey, oh, you know these. You can think about when you've done them or when you've had a student, if you're a clinical instructor. These are the common clinical reasoning issues, and almost all of them are kind of that, I want the answer. I don't want to be uncertain, I want the answer. So you find something, oh yeah, I think it's that, I think it's an SI problem. Or you confirm too early, just the first thing comes to mind, you can't frame it properly, you go, oh, I think it's this kind of, I just went to this course and I think it must be an SI problem because I went to this course. Or maybe, oh, it must be I must be able to use dry needling, I'm sure, right? That drives me wild. It's the answer to everything, right? Well, it's not, but almost all of these are stopping too early, and novices want certainty. So they don't want to mess in the swamp. They don't want to stay in the ambiguity. That's the challenge, I think, for the mentor, for the CI, for the educator, how we get students. And I'm fond of saying, we also need to ask learners, okay, what didn't you understand about this? We do this in ethics when we use a standardized patient thing. We have them do reflection questions. We say, what were you uncertain about? What didn't you understand? Where was the difficulty? And if students can't come up with that, it means they're not thinking very deeply. So you want to have them struggle. You want to have them bring that struggle out instead of chasing the right answer. And that's on us. That's on the education side, for sure. So they're going to keep pushing on that. So, but they need to have psychological safety too. They need to, there needs to be an environment that welcomes that kind of stuff. And once again, here's novices. This is from the early work by Dreyfus and that are pretty well established. That novices, they like the facts, man. They want certainty. But we want to start to move them to begin to see a situation awareness. We want them to use intuition and begin to develop competence. The challenge is, as you get more expertise, as you get more proficiency and expertise, you become more intuitive. That can be good to it, but it also, novices, this is where Ron Epstein writes about this, that novices can be extremely helpful when they're with experts, because they'll ask questions, you know, I never thought of that. So novices can help by asking questions, because experts, you tend to take shortcuts, it's intuitive, you're not making it explicit, but novices bring that piece out. So this is where a diversity of learners is so important. We did our national study, one of the things we studied PT programs, Washington, and we studied clinical facilities. And we wanted programs to have a connection to residency programs. And what we found is how important having different levels of learners in the learning environment, in the lab, in the classroom, and in the clinic was really important. And we had CIs that would say, you know, I'm a mentor with our residency program, and I become a much better CI because I've been working with residents and thinking more about clinical reasoning and what I have to do. Now, they have to be careful to not overdo it, but you know, we've got to see that on a continuum, and I think we have not done a very good job. Okay, here's what you do your clinical experiences. You go to wherever you get matched or whatever, right? And then you go, well, then you decide to go to a residency program because you feel like you have it, or you want more. So we've still got work to do, for sure. Okay, so teaching strategies, we've talked about, you know, how do you optimize, not too much load, 5 things, remember. Typical cases, simple to complex. You can change the case features, you know, here's a case with osteoarthritis. How does it look different if the patient had rheumatoid arthritis? How is that different? Why is it different? Compare and contrast. Talking out loud, think out loud, both for student, for learners, as well as mentors. And can you visualize that process? Yeah, how do you think about putting your knowledge together? That's where making structure and the maps and the body charts are really helpful, because you're starting to get, okay, how do you put all this together? Intentional pauses, you know, just give time to go forward, review the essential concepts, near peer opportunities. That's where different levels of learning, the community is really helpful. Show solved cases, that helps. Said, okay, here's a script, here's a solved case. Think aloud, think aloud, think aloud. It's probably the most powerful strategy in the clinic. Simple, most these kind of repeat. So, and then limit feedback. You know, in the 5-minute preceptor, if you know the 1-minute preceptor is kind of what did they do right? Start with that first, then get into, okay, you didn't do this, so here's where you could do that. But start with something that's right. Hopefully you find something that's right. That's important. And then you're trying to do the knowledge translation. So clinical reasoning has to have that clinical knowledge. It's not just, that's where learners struggle if they're just going, okay, here are the facts, here's what I did in the classroom. If they can't make that translation, they're going to struggle. So practice and reasoning requires practice, and both pointing out the kind of analytical process as well as the context. Why did you come up? What was the patient preference here that made a difference? That was important. And then motivation and emotion. Build self-efficacy for learners. Again, tell them what something they did right. Stories are powerful. And we've used clinical narratives in the residency program for quite a while. And they've been rich, and narratives go beyond your kind of age diagnosis. And here's what I did. That's where you get the story and context. And peer-to-peer or near-peer learning is powerful. These are just examples of scaffolds, but these are, you know, thinking questions. What do you think this is? What's going on? Micro skill, again, reinforce what's done correctly, and then move into not so. And summarize, these are used in medicine a lot. SNAP, summarize, narrow, analyze, probe, plan, select. It's just a structured scaffold to get an approach of what you're thinking, how to get it. And concept mapping. You've probably done concept mapping in your academic, your GPT program, maybe. It's nice. You can do one, you know, at the start, and you can do one at kind of the end of your of a unit or a semester, and learners can see how much more they know and how those things are connected. If all they're doing is memorizing, you know, they're never going to get to a deeper. Those are learners that struggle and probably don't make it. All right, and these are just a couple examples. I was telling Kyle, we have a learning lab group, just like Colorado has a learning lab group, Washington has a learning lab group. These are folks that are colleagues like us that are doing education research. Heather Knight is heading up a study right now. We're looking at, with clinicians, looking at strategies. These are teaching strategies for clinical reasoning and how we can do a better job with knowledge translation. And these are available. These things, you just download them from our. Here's one on learning 30-minute cognition, think aloud. And here's another one. What kind of questions can you ask for metacognition? How can you decrease and increase cognitive load? And there'll be more coming out. She had an education research, education academy practice, doing some really good work. All right, what's the future? Is AI going to replace us? What do you think? I think medicine has more of a risk. Certain areas of medicine have more risk, and I think they are. And I don't know if you saw this. This paper got a lot of press, and they did a randomized clinical trial, and they used the large language model. The AI did better. Alone outperformed physicians even when the large language model was available to them. So, not that it's going to replace them, but the downside, the risk with AI is there is some evidence to show that we're getting some cognitive de-skilling, so critical thinking skills, which are really important. Starting to see learners. So not to think about our learners, grade school, high school, and where they're going to be when they get to college. Yikes. So I think we're pretty safe, quite frankly, because our diagnosis is kind of messy. Wouldn't you say that? Yeah, it's contextual. So it's not like you're going to feed it into AI and now with writing, that's a whole different things. But I think, yeah, it's a tool. It's going to be a helpful tool, but it's not going to replace us. That's it. So we talked about. Do people want to make some comments about special remembrances about Phil?
You want to tell the?
Yeah, you can tell them, Kyle.
Okay.
Tell them, Kyle.
Well, thank you.
Yes.
First. I think we're gonna also open it up if anybody wanted to say anything special about Phil too. But thank you so
Yeah.
much for your talk.
And questions.
And questions, yeah.
Questions, but I would love to hear more comments about Phil. More.
Yes, I feel her, for those that have met him, or Phil's brother, other members of the afternoon. But yeah, one of the things I was thinking about when Gail was talking was something I was admired about Phil. He's always kind of an all-in person. Like I remember in high school, like he loved playing, like he loved playing baseball. Like he was kind of short and he liked he was a catcher too, so I didn't really play. So yeah, I was so then I was on the cross country team. He joined the track in that spring, and then cross country in the fall. And like from then on out, didn't want to have anything to do with baseball. It was track, running, cross country, all of it. They kind of like it didn't care, like that's all I wanted to do. Run. And like I thought it was like then he got into physical therapy. Like I think towards the end of his undergrad, he kind of got into this natural extension running. And then he like took an extra year to get some science elective or science classes done, then put a grade for therapy school. And then it wasn't just enough to be a therapist, you had to go. I don't understand all works, but he spent some time in school in Montana, there maybe I don't know, he had a practicing residency program maybe, and then he ended up doing a fellowship with Western, and so again, he's never wanted to just be kind of lackadaisical about running and we're like, oh, I'll be able to serve this like just a physical therapist.
Yeah, I think he's the epitome of who I think of when I think of a lifelong learner. So yeah.
comments, right?
Said we did a first study about 30 years ago. Well, I was in the office in your study.
Well, yeah, that was the pre-work we did before we did the next stuff. Yeah. we did. Well, maybe it was more than 30 years.
I have a question. So I think AI is becoming more and more prevalent, obviously, with even utilization like DPT level 2. Do you see any ways that we can use it in a positive way where obviously what you kind of laid out is we can't rely on it completely or we lose the clinical reasoning process? Is there a way we can use it beneficially to create, I don't know, complex cases to work on, or like, what do you think?
No, that's what I suspect, yes, yeah. There are ways, I think, I think in medicine, if you would, at the Education Leadership Conference this fall, it was in Kansas City, Martin Clusick gave a keynote. Martin he's at Harvard, he's a physician, and he's very involved in precision education. And he talked about how, when he works with his medical residents, right away, he has them first go, and he uses it himself, open evidence, and then he uses research record. So he uses a couple of things, but he also is guiding and knowing the danger of using some of these evidence things is if you don't know what might be hallucinating, can, or what, wait, that's not really an article. That's a problem. But I think it can be helpful in saving time and in creating complex cases. And I think it'd be a very useful tool.
Yeah, I wonder, like, instead of just asking what the answer is, because I know as a novice learner, you just want to know what to do.
Yeah.
Like, I wonder, utilizing it for backwards thinking, like, well, why is this the right answer?
Yeah.
So I think that makes.
Yes. Yeah, the thing about using it is you can use it, but then you can be, one of the ways to use it analytically is if somebody uses it, okay, now, what did AI do? Can you make this better? Or what's right or what's wrong? And that's kind of what they're doing on the writing. So, because the reality, like in our medical, I can tell you, the students, they don't want students to write reflections anymore in the other humanities section, because they were using AI. So now when they write the reflections, they have to do it in class on paper. Or they have to do it right there on the computer. Watching them.
I think what AI is missing is contextual factors of what we do. Right? It knows numbers and digits and how to connect those two things, but doesn't know the human nature of what we do. And so a lot of it, that's why it probably does really well in the radiology department. It can analyze pictures and that's great. Go back and forth between diagnostics, but the contextual piece.
I think you'll see more on chiropractic. That's part of this hepatics, touch, pressure. I mean, that certainly applies to us. And manual therapy, the Australians could try to do that for you. Can you really, is this really a grade 1?
Yeah, I feel like it's one thing to say, okay, my car's making this sound, break it down what's going wrong, but we're not mechanics. We're working on patients with emotions and feelings, and makes it a little difficult to contextualize, I think.
Is there anybody who answers questions?
Any other questions
You
from?
can take the slides and you can have them all show.
Oh, yeah.
Show.
Gail, it makes me a little nervous that you have Phil's reflection from when he was in school. I'm hoping that you don't have any of my reflections sitting around anywhere.
I can look, Jake.
Makes me nervous.
I
I have a great memory of Phil, just to kind of bring it back to that. This is such a great event, Kyle. Thanks for organizing this. Phil was our first resident at the University of Montana in our orthopedic residency program. He rode his bike every single day. He did it for 1 year, 365 days. He rode it every year or every day. And there was one day in particular, it was in the negatives and it had snowed hard, and he showed up and his eyelids were frozen and he had frost on his eyelashes. And that was just Phil. Like he just had that tenacity, and he was going to go do whatever he wanted to do and put the effort into it. And so when he said he was going to bike every day, sure enough, he biked every day. But yeah, I mean, this is just Phil was kind of the classic master adaptive learner. I mean, he asked a lot of really deep questions that made it hard to be a mentor for him, and challenged, I think, a lot of us. But just such a great human being, and miss him a lot.
Call on
Josiah just had a heart.
him.
Alex, you got anything? Leanna?
Brayden, how about Brayden or Paul? Come on.
I was
you
gonna
guys.
say I can speak to Phil. So I I was I'm Braden. I was a classmate of Phil at Creighton. Um and a story about Phil. So we were on one of our longer clinical rotations at UIC. We were staying in this student housing, paying tons of money a month, trying to survive a rotation that was pretty intense. But we wanted that. Like we searched that out, and that's just Phil. You know, he just wanted the baddest program out there type thing of a rotation. And that energy was uh you know, I was influenced with that, and you know, I just wanted to follow Phil basically because I knew he was I wanted to be like him basically. Well, and then the story, so this was in the winter. So one of the things in his discipline, you know, he's, you know, we've mentioned he's a cyclist. He's also a, you know, an avid runner. And at that time, you know, we were, you know, doing our notes at night and having discussions of you know, what we're learning, talking about, you know, CI stuff and how we see the profession going, and you know, just ourselves developing our early on philosophies, I guess you could say, of how we want to move forward in our careers. Well, in the midst of this, you know, he's running miles and he's telling me on the weekends how, you know, how far he's running. I wake up one day and I didn't know where he was. I'm like, oh, he's on a run. I didn't see him till, you know, lunchtime. And he said he just ran a marathon on his own, the distance, but he didn't sign up for a marathon. He's, you know, he was too cool for that. Um, so he ran the entire, you know, Chicago boardwalk, you know, along the lake, all the way north of Wrigley, and then came back. And this is, you know, it had snowed. It was, I don't know, 10 degrees. Like he just ran it. And that was Phil. So I greatly enjoyed that rotation. You know, I think, and that was where he kind of talked about him wanting to do the fellowship. At that time, it was through UIC, and then he, you know, went on when it moved to Northwestern. And he was kind of that rotation, and for him, it was part of the reason why I decided, hey, I want to be more than just status quo. And he influenced me with that. And to this day, I greatly miss him because I always, and I had a PT question, you know, I called Phil. Through COVID, there was like 4 or 5 of us. We would go on like weekly, or I don't know if it was weekly, but like Zoom meetings, just talking PT, just to get some socialization, but you know, but make it kind of useful. And yeah, I miss him greatly, and I'm appreciative of this, and you know what Creighton has done, his influence in Montana with Jake. You know what you've done there at Northwestern, at UIC. It just shows that he had such a huge impact everywhere he went, and just so thankful for Tom and Vicky and his family, um, and just their blessing with us being able to continue to do things like this and to keep this Phil's spirit alive. it's just really nice.
Thanks, Braden. That was awesome.
I'll just say a really quick little thing. I don't have a really super fun story like everybody, but I had the pleasure of sitting next to Phil at UIC for a really long time. Our desks were right next to each other, and just the shenanigans we got up to during COVID, trying to stay sane and sitting next to each other. There was this like pillow thing that somebody had left in the like the shelving unit above our desks. Nobody knows where it came from, but it was a pillow thing that you would put your head in and then put your hands in the sides and like lay down on your desk to take a nap. And one day Phil put that on with, the full PPE that we had to wear at the time, mask, the goggles, like everything. And then this like ridiculous pillow thing. And we just could not stop laughing. So I just admired his ability to just bring people together, even in hard times, and just find things to laugh about, even when it feels like there's nothing. Oh yes, that's the photo. Thank you, Kyle. Yep, that's it. That is it. The napping pillow. And I also just admired, along with, he was an avid cyclist, runner, and all of that. He also loved coffee so much, and I'm also a coffee lover. But I really appreciated that he was like the one person that I would see drinking coffee at his desk out of an actual mug, and not like a travel thing with a little slider top, like an actual mug. And he just would like take the time to sit there and enjoy that. And I just appreciated that aspect of him so much. So I miss him. He was an incredible human. So we're lucky to have known him.
I'll just echo everything that people have said. But he was a classmate, but in some ways he was kind of like one of my first mentors. And like Braden said, during COVID, we were doing these like journal club things, and I just remember he always had such a thoughtful perspective, kept things so kind of level-headed, but was able to give really insightful discussion. And that was really meaningful because I think he was sort of working at that time, but I definitely wasn't. So all of that was really helpful. And then lastly, just he had a really major impact on my own decision to kind of go through and do a residency much later in my career than most people do. And I'm so grateful I did that. It's been so impactful on my own clinical decision making, but also how I work with my patients. So.
You're in charge, Kyle.
Anybody else?
Sure, could we get everybody in front of there?
Yeah, that'd be awesome. If you guys want to turn on your cameras, we're just gonna take a picture. One up front. Oh, this is cool.
Come on.
Oh.
We could come over here. Yeah, so you can see.
Actually, you can do it with what?
Really?
Tyler, are you going to give us a countdown or something so we're not like frozen in awkward positions over here?
I want you to keep smiling. I will tell you.
Oh, perfect.
Yeah. Let's see. Sarah with the right line. So.
Okay, sounds good. There's
All right,
plenty of
It's gonna
space.
be 10 seconds. 6. 3, 2, 1. Never taken a picture of the screen.